Okay, good afternoon, everyone. My name is Mahdi Tavakoli, and I'm with the Electrical and Computer Engineering Department at the University of Alberta. So I'd like to talk about robot-clinician collaboration in semi-autonomous computer-integrated surgery and therapy. I'll talk about both surgery and therapy, and I'll try to talk about these levels of autonomy because that's one of the really main focal points of this autonomous systems initiative. So probably for this crowd, I don't need to really talk about the motivation for having medical robotic systems. You have heard all the other speakers they talk about the advantages provided by these systems. But in general, really, it's the aging of population, the presence of basically baby boomers, and because the rate of fertility after the Second World War was pretty high in Canada and the US, and in some other countries, as you see, the rate of fertility was very high, and now it's they've all dropped. So there is an old population that is putting pressure on the healthcare system. 2020 is the first year in recorded history where the number of people over age 65 in the world is more than the number of people under the age 5. So this is actually putting pressure on the healthcare system. On top of that, we have had COVID. So COVID has completely strained the healthcare system to the limit. So had we developed robotic solutions previously and invested in that research and development earlier, robots could have been used. And of course, they were used also to some part during COVID to reduce contact times between patients and frontline health workers, or between healthcare workers to reduce the risk of cross-infection. The robots could have been used for things like curbside screening of patients before they enter the hospital, or for doing things in the ICU instead of sending a clinician into the ICU, which is a very dangerous environment right now because of COVID. So for instance, during intubation, really all of that is being sprayed out when they put a tube in the lung. If you're interested in this topic, we wrote a perspective article that you see at the bottom quite early on in the pandemic, and we talk about different ways robotics can serve. So we, for instance, talk about various types of robotic systems and how they can cater to various parts of the spectrum of care, going from primary prevention, screening and material handling, to acute and emergency care, and then outpatient care, and even for medical education. If you're interested, please read this paper. So just to quickly show you what robots could do, or maybe did for the case of COVID, I'm going to show you a couple of videos. So what you see on the top left is a teleoperation system where a sonographer, of course, a simulated person doing sonography here, on a patient that is lying on this table, again, a simulated patient, can do sonography over a distance. Okay, so this is a teleoperation system. It can create physical distancing, and distance can be anything that you want. So these systems are useful for combating COVID. But you don't have to have such a sophisticated system comprised of two probably very expensive robotic systems to be able to do such a thing. We have recently worked on other ways of doing healthcare service delivery through a 2 meter or 6 feet distance. So we call that distancing aware healthcare, where you can just design low cost, 3D printable, human powered robots that just allow for distancing between the clinician and the patient. So I'm going to show you an ultrasound scanning done through a distance, but the same idea can be applied to oxygenation, swab taking, you name it, prescription drug delivery and things like that, while the clinician is allowed to be somewhat far from the patient. So you can imagine that, for instance, for the case of sonography of heart, a clinician needs to be next to the patient for 10 minutes to take heart images. So we allow some sort of a space between the two, and this is how robots can actually help with this healthcare crisis. So we are going to talk about levels of autonomy in medical robotic systems. And there is the possibility for collaboration between the clinician and the robot, and there is the possibility for full automation of the entire operation, being it surgery or therapy or diagnosis or whatever, so that there's no need for clinician. Where do we want to go? That's the big question. So if you think about the automation level, you could have zero automation where everything is done fully manually, or you could have full automation where everything is done fully autonomously and nothing is left for the clinician to do. So on the right-hand side, I kind of show this split of tasks or sharing of autonomy, sharing of tasks between the clinician and the machine across these different levels of automation. We are really not interested in fully manual because this is the traditional method. We are not interested in the fully autonomous case of machines that are fully autonomous, because that doesn't leave anything for the clinician to do, and you're kind of throwing away years of experience and training of the clinician. We are interested in these mid levels of autonomy where either the clinician is doing all the tasks but is receiving rich information that enables the clinician to do more, or some tasks are given to the clinician to do. Those tasks are usually safety critical tasks or tasks that require judgment, and you delegate certain tasks to the machine. Those are tasks that possibly require computation and are computationally expensive. So I'm interested in this talk in this sort of a split of tasks and autonomy between a clinician and a machine. And I want to show that to you through a few examples. So this topic is becoming quite hot in the research community. If you look at the paper at the bottom, this is by another group. They talk about this kind of a staircase of autonomy and how we should be going basically from no autonomy and to robot assistance and having autonomy for performing one task, all the way to having autonomy for a number of tasks, making decisions, making planning, and so forth. So right now we are at the robot assistance, or maybe for some systems at the task autonomy level, but definitely we are not up the ladder yet. So I'm going to focus on this in the middle of the spectrum, where there is some sort of shared control between the surgeon or the therapist, the clinician, and the machine. And usually the clinician is doing something that's safety critical, whereas the machine is doing something that's computationally expensive and difficult to do for the human. We can't talk about autonomy without talking about what kind of a robotic system are we going to use. And what kind of a robotic system you're going to use depends on the uncertainty of the task. If the task is highly uncertain and you don't have good knowledge of it or a good model of it, you have to keep a human in the loop and use a telerobotic system where there is a main robot as a user interface for the user, for the clinician, and there is a secondary robot that mimics the motions of the clinician on the patient's body. If the task uncertainty is low, you are good to use an autonomous system and reduce the role of the human to some sort of supervisory control. And in the middle, you can have collaborative robots where the human and the machine together are doing something on the patient's body. So I'm going to show you this, kind of talk about this story through a few examples. So I'm going to start with surgery, talk about beating heart surgery, go to therapy, cancer therapies for prostate and for breast, and then go to rehabilitation of people who have injuries or disabilities, okay? And I'm going to talk about some engineering technologies that we have developed in the lab. And of course, this has been our choice. This has been our trajectory. There is no reason to necessarily use the engineering technologies on the right-hand side for the problems on the left-hand side. Any other combination may be possible. I'm just going to present to you what we have done and bring home that message of sharing autonomy between the machine and the human. So let me start with beating heart surgery. We want to operate on the heart without stopping it, which is currently the way that it's done, but it has side effects because you have to stop the heart, put the patient on the heart-lung machine, perform the operation, and once the operation is done on the heart that's not beating anymore and is emptied of blood, reconnect the heart to the patient's body, warm it up, massage it, and shock it, and let it run again. So that procedure has side effects and is risky. Can we operate on the heart without stopping it? If you want to operate on the heart on the left-hand side without stopping it, it's like trying to land this chopper on the deck of this ship in choppy waters. So as you bring down the helicopter, the deck of the ship can come up and can kind of hit the helicopter and destroy it. So this is a very difficult problem of controlling the distance between the bottom of the helicopter and the top of the deck. You have to control that distance through the joystick available to the pilot. This is a difficult problem for the heart because of very fast accelerations and velocities of the heart. So I'm going to talk about this split of task and sharing of autonomy between the clinician and the machine, where the machine does the job of motion compensation so that the clinician and the surgeon can focus on doing surgery the way she would do it on an arrested heart. So what I'm going to talk about is letting the machine automatically synchronize its motions to the motion of the heart so that there is zero relative distance between the tip of the instrument and the closest point on the heart. And then I'm going to let a surgeon manually, through these joysticks, control the distance between the tip of the instrument and the closest point on the target. To do this, we have to put the patient under ultrasound to be able to see the closest point on the heart, and also to see the surgical instrument and calculate the distance between them, which is to be controlled according to the position of the surgeon's hand motion. So the displacement here is going to have a reference value which is equal to the position of the hand of the surgeon. This is a very difficult problem because ultrasound images have delays by the time you process them and acquire them, and also they have a low sampling rate, about 30 hertz, whereas you need to control your robot at a very fast rate. So I'm not going to go into details. If you're interested, please look at the papers that are listed at the bottom, but really it comes down to the problem of controlling the distance between the robot and the heart to be following the surgeon's hand position. So if you want this to happen, then the robot position has to be equal to the surgeon's position plus the heart position. So after image processing, the position of the heart is found. Of course, it has delay and has a low sampling rate. You have to upsample it and then do some sort of prediction using Kalman filtering, for instance, and then add that heart position to the surgeon's position and make that the reference value for the position of the robot. If you do that, then the goal that I mentioned will happen. So I'm going to quickly show you some videos about how this is done. The first one is, for the case of pericardiosynthesis, we have a simulated mechanical heart. There is a sac of fluid around the heart, simulated heart, and through a syringe connected to this surgical robot, and using this user interface, the surgeon is trying to withdraw that fluid from around the heart. So without motion compensation, without this autonomy or semi-autonomy being added, the surgeon, simulated surgeon, would have to move the user interface to control the instrument. Let me go back a little bit. To control the instrument to beat with the heart, and at the same time control the tip of the syringe to penetrate that sac and withdraw the fluid. That's very difficult to do. But with motion compensation, the hand of the surgeon is steady, that distance is controlled, and the surgeon makes small movements to close in on that sac and withdraw the fluid. For the case of mitral valve replacement, this problem boils down to stapling a ring on the annulus of the mitral valve. So it's a stapling problem. And I'm going to show you the results of that done under ultrasound imaging, through ultrasound imaging, which is seen here. So the surgical instrument is being moved up and down in synchrony with the heart, or the surgeon is attempting to do that. The user is attempting to do that. It's very difficult to do that and staple the tissue correctly. So users kind of give up after some time. But when you have motion compensation, which is what you will see now, the instrument moves automatically by the machine together with the heart, and the user only has to control the distance between the tip of the instrument and the heart tissue and deploy the staple at the correct time. And users were able to actually do this successfully. For a similar application, sonography of the heart, echocardiography, or sonography when the chest is moving up and down, we are showing the same thing. This robot is moving the ultrasound probe to be able to scan the tissue that is beating due to respiratory or heartbeat motion. So that motion is automated, and the clinician can focus on controlling the sideways motion of the probe so that you get continuous images by moving the probe on the tissue. So that was one way to share authority between machine and the human. I'd like to show another way to do it through another application example, and that's prostate brachytherapy. So in prostate brachytherapy, the goal is to kill the prostate cancer by implanting radioactive seeds permanently into the tumor or around the tumor that's within the prostate. So this is done by a procedure called brachytherapy, where a number of long needles that are hollow and carry radioactive seeds inside are inserted into the prostate, and then those radioactive seeds are deposited permanently into the tumor. This procedure is done under image guidance, and image guidance is provided by a transrectal ultrasound probe. So this is actual surgery that's happening at the Cross Cancer Institute in Edmonton. I hope you don't mind watching this. This is the transrectal probe for ultrasound imaging. This is the needle. Once the surgeon is able to see the needle under ultrasound and knows that it's been inserted to the correct depth, then this stylet is held in place and the needle is pulled back so that the stylet can push out those radioactive seeds, and hopefully they end up in the correct location in the prostate. I said hopefully because this procedure is not as easy as it looks. These needles are highly flexible, and as they enter the tissue, they bend. Therefore, they end up where they do not end up always in the planned location. The needle bends and the tissue also compresses, which moves the target tumor. And therefore, there are radioactive seed misplacements that may result in killing healthy tissue and not actually treating cancerous tissue. Why does this needle bend? Because to be able to cut tissue, these needles are made to have this bevel. And because of this bevel, there is an imbalance of force acting on the needle tip. There is basically this net force F acting on the bevel of the needle, which makes it go down. The good thing is that this is also your control input, meaning that by 180 degrees rotation of the needle around its long axis, you're able to turn the bevel up and actually make it go and bend in the opposite direction if you want to correct its path. So that's really our control input. So to control these needles, you have two inputs, the insertion speed and the rotation speed. You can fully automate everything as it's shown here. So it's a feedback control system where the needle has to go on a trajectory that has been planned. You can measure needle trajectory through sensors, which are in this case ultrasound images. You can do a state observation to measure all, not only the position of the tip of the needle, but also its orientation. You can do trajectory planning and prediction to overcome the non-holonomic constraints of the needle. And then finally, you can do control based on a combined model of the needle and tissue interaction. You can do all of that. But what is left for the clinician to do then? There's nothing left for the clinician. And this is not accepted. It's just not acceptable clinically. So what we did was to ensure safety and to ensure clinical acceptance, we gave only one of these two inputs, which is needle rotation, which is computationally expensive and requires sensing, modeling, path planning, and all of that to the machine, and gave needle insertion, which is safety critical, to the surgeon. So that's this sweet and happy medium that we found, and our collaborators believe this is actually the way to go. So that's the split of tasks. The surgeon is doing insertion, whereas the machine is doing the rotation, which actually determines the path, and that's the hard thing to do. So as you see over here, first there is a scan. So this is a 2D ultrasound probe, just doing a scan first to see how many seeds have been deposited. So then the surgeon inserts the first needle, not just by holding the needle by hand, but through this handheld device that we have. These path planning algorithms that I mentioned to you by the machine. So that is ensuring that there is good autonomy sharing between the machine and the clinician. This is good because it can allow you to place seeds with high accuracy, an accuracy that surgeons cannot achieve freehand. Even experienced surgeons have about 5 millimeters of error in positioning seeds at the tip of the needle after inserting them for about 140 millimeters. But with a device like this, you can actually achieve sub-millimeter accuracy in placing seeds. I want to move to the next case for sharing autonomy. So this is about breast brachytherapy in women who have breast cancer. And this is something we are doing with Tom Baker Cancer Center and Edmonton's Cross Cancer Institute collaborators. So the goal here is to translate all of this technology that we have developed for prostate brachytherapy to breast brachytherapy. The first step of that, which is an ongoing project right now for us, is good ultrasound imaging of the breast so that we have repetitive scanning that can be used for visual surveying and image guidance of these needles. So our goal right now is to do ultrasound imaging, basically do imaging of the breast in a repeatable way, only based on ultrasound and without having to rely on mammogram and X-ray. So breast cancer is the most commonly diagnosed cancer in females. Diagnosis and screening of the breast cancer is currently done by X-ray, where the breast is compressed, and then from the top an X-ray, a 2D image basically is obtained. Well, it has two disadvantages. The first disadvantage for this approach is the ionizing radiations of X-ray, and the second one is that you are imaging the breast in a compressed form. If you know where the breast is in that compressed 2D image, how do you know where the 3D, where the breast is in 3D when the breast is on the form for surgical removal? So what we're trying to do is to use 2D images of ultrasound. Unfortunately, most of these breast tumors can be seen in ultrasound in a repeatable way, and by sharing autonomy between the sonographer and the machine for best image quality. So this is something that we are working on. Here we have a robotic system that's impedance controlled so that as it holds the ultrasound probe, it can be moved freely to the in the tangential direction to tissue by the clinician, while downward forces that determine the image quality of ultrasound are automatically controlled by the robotic system. So, So as the sonographer moves the probe sideways, the downward pressure is controlled automatically, and we're working on controlling it after doing analysis of quality of ultrasound images in real time. So as an aside, one of the issues is that, whenever you design a robotic system for medical applications, the question is cost and complexity. It's quite costly to buy these systems. Not every clinic can do it. And also, it is difficult to prove the safety, and there's all the complexity around it. So we are now trying to develop systems that are more mechanically smart and cheaper, such as this system that automatically conforms to the surface of the breast in terms of its motion and has a spherical motion without you having to actually control it to have a spherical motion. As the fourth application, I'd like to talk about haptic virtual fixtures, augmented reality for rehabilitation of injured workers. But before I talk about rehabilitation of injured workers, I want to show you some of the more standard ways of using haptic virtual fixtures and augmented reality for surgery that we've done, and then make the bridge to rehabilitation of injured workers from there. So this is something that we have done in collaboration with researchers at the Institute of Reconstructive Sciences in Medicine in Edmonton. For people who have jaw cancer, the jaw is removed, and then you have to cut a bone, basically the bone from the leg called fibula, in such a way that it makes a snug fit, and it can be actually transplanted, and that grows with the rest of the body. So for this procedure, it's very important to make the cut precisely so that there is a good fit between the jaw and that cut fibula. So what we have done is we have programmed virtual fixtures to this robot that is holding the surgical saw, so that this hands of the user or hand of the user is guided toward the correct cutting plane location, and the user is unable to make any mistake, basically. So still the user is doing the task, but guidance is provided in a way to ensure safety and precision of the procedure. So this is what we did a while ago. Then we were intrigued by how augmented reality is changing the world, really. For instance, in F-35 fighter jet, this pilot now has 360 degrees view, meaning you can actually see through the body of the plane because there's augmented reality, and you can see things that you wouldn't otherwise see. So we have worked on using this semi-mirror or half mirror, where you can see through it, and you can also see the reflections of things shown on a monitor as co-located on the physical object, so that as the surgeon is cutting the fibula, the surgeon's hands are nudged toward the correct location to cut, but at the same time, surgeon's eye can see those cutting planes as floating in space. So that's the thing that we have done. It's unfortunately a little difficult to show augmented reality. You have to be there and actually move your head and see these planes get updated to be able to kind of appreciate what it's doing for you. What you see here is virtual reality, which is kind of just a TV display showing, where cutting is happening. But when you have augmented reality, you will actually see those cutting planes as floating in space to provide enhanced situational awareness to the surgeon. So now we have used this for rehabilitation of injured workers. So we would like to artificially recreate work environments for assessment and rehabilitation purposes following a work-related injury. If a person is injured during the performance of their work, they are sent to the clinic, and FCE, or functional capacity evaluation, is performed, which basically is a set of standardized tasks that the user or the patient, injured person, would have to do, and then they receive a score that is assigned to them by the physiotherapist. This is kind of a low resolution assessment and can be subjective and variable. Also, in the clinic, there are all sorts of hardware for different occupations. So if you are a postal worker, there is actually a mailbox with lots of envelopes for you to put into different locations as a way to be assessed or be trained on how to do it to overcome the injury and so forth. So this approach requires both a lot of space and a lot of hardware. What we have tried to do is to use a robotic system with haptic feedback capabilities and an augmented reality system to artificially recreate any of these jobs that are done for now by one hand. So that's what you see here. There is an augmented reality display that can create 3D augmented reality for the user. And then you have this kind of task simulator. So just like a flight simulator that haptically recreates the dynamics of the flight for the pilot, and also recreates artificially the view that you would see outside the cockpit. This is what that does for you, but for different tasks. And there are all these benefits to it that I don't want to go into details about. This video shows you how the system works. For the job of painting a wall, for instance, this user, when 3D is on, would actually see a wall floating in space and would feel that through the robotic system. So you would, if you want to go into the wall pushes you back and you see it in 3D and you actually can paint it. And we will be working on extending this simulator for different upper limb tasks. The last thing that I want to talk to you about is, again, focusing on that question of sharing autonomy. How can we bring AI into the system so that the robot learns from how a human, a clinician, is doing something and repeats that in future iterations of that task? Okay, so that's a different level of sharing. That's a kind of a temporal splitting of task. First, the clinician does something, and then the machine learns it and repeats it into the future. So we have done this for rehabilitation of people with disability, and really the goal is use AI to let a physiotherapist teach a robot how to treat a patient. So using a robot that is equipped with AI, we can use the robot, learn from a physiotherapist, and deliver that therapeutic behavior for a patient in future iterations of the same task. So post-session rehabilitation is very cumbersome and physically demanding for therapists because they have to physically interact with patients and engage in these assistive or resistive therapies. Robots have been used to reduce the workload of therapists, but as you see, as you see over here, there is almost nothing left for the therapist to do. The user is playing a haptic virtual reality game with a robotic system, using a robotic system, and there's nothing for the clinician to do. The clinician is just observing and maybe giving verbal commands or changing something on a keyboard. There's no way for the physiotherapist to engage in a hands-on way, while not as much as they would do in manual or conventional physiotherapy. Also, these robotic systems, the way I'm showing it here, they don't add anything to what a physiotherapist is already capable of doing. So these are all limitations of robotic systems. The tasks are also very simple. It's just point-to-point motion, reaching motions. It's been shown that learning how to make reaching motions doesn't necessarily translate into learning how to perform activities of daily living, such as what I'm showing here. Okay, so it's best if these activities are integrated from the start into the rehabilitation program. So ask and help a patient to put a key into a lock and actually open the door, or open the fridge door, for instance. Get them involved in actual activities of daily living so that the results are better translated into daily life following the rehabilitation is terminated. The problem is activities of daily living are performed in unstructured environments and are very different. So if we're talking about having a robotic system help a patient open a door, what kind of a door are we talking about? Is it a rotary door or is it a hinged door? Where is the knob? And what is the shape of the knob of that door, and so forth. So it's very difficult to have one program for a robot to be able to do all these activities of daily living. It's almost impossible. One way to overcome this problem is to bring in an able-bodied person to show the robot how to perform that task in 1 or 2 or maximum 3 iterations, and then step back and then let the robot learn that behavior from human demonstrations and repeat that behavior for the patient. So this is what we have done, and that's this area of machine learning called learning from demonstration or imitation learning, where there is first some demonstration provided by the therapist for the patient, and then the robot understands what was that the therapist was doing for the patient. And in the absence of the therapist, because the therapist time is very expensive, the robot will continue to deliver the same behavior or the same therapeutic behavior for the patient so that the patient can receive a higher dose of therapy. So I'm going to show you this concept through videos. At the top, you have a patient who is supposed to open this drawer as an activity of daily living, but can't do it due to disability. In the second iteration of the task, a therapist comes in and intervenes and shows the robot what should be done. The robotic system has seen what the patient alone can do and what the patient plus therapist do, and subtracts them statistically and figures out what was that the physiotherapist did and delivers it in future iterations. It's as if the physiotherapist is there and actually helping the patient, but without the physiotherapist really being there. Another example is what we have done with Hossein here. So this is the case of a person, a simulated patient who can't walk because of problem clearing his left toe. A physiotherapist, a simulated physiotherapist, is pulling the left side of the patient's body up at the correct part of the gait cycle. The robotic system observed that, and without really knowing what the task is, and just based on data, figures out what it needs to do to give the patient more opportunities for receiving therapy. We have done the same thing. We've done the same thing for children with Dr. Kim Adams from Faculty of Rehabilitation Medicine. Children who have a physical disability need to have opportunities to engage in playful activities. If they don't, that physical disability can lead to future cognitive deficiencies. So it's very important that they engage in physical activities and are actually successful in doing them. So a child that has hand tremor should still be able to perform this game successfully, to be able to engage with other children and play. So we have done this learning from demonstration for this application as well, where this is the simulated patient who can't have smooth hand motions. A helper, could be a sibling, could be a parent, comes in and helps the child perform the task in a few iterations. And then the robotic system figures out what was required for this patient and delivers it in future iterations so that the child could continue to play and enjoy. So this is what you see on the left-hand side for a simulated patient, on the right-hand side for an actual person with actual disability, although she's, of course, not a child. But you see that, for this 2D game of, hot wire, first, our patient can't perform the task successfully, which is not good. A helper comes in and helps them, smoothes their motions so that they can do the task. And then the robotic system figures out what help was required by comparing the patient alone with the patient plus helper, and finding that model that is the therapist's behavior represents, and reproducing that in future iterations of the task for better engagement. So as you see in a second, then the user will be able to continue that task in future. I'm ending nearing the end of my talk. We've done this also for telerehabilitation. So home-based rehabilitation is also important to be able to have therapists contribute through a distance to how the user is performing tasks, and then the patient side robot learning that behavior and reproducing it in future. So as an example, in the top left, you see that a simulated patient in the forefront and a simulated therapist in the background, they're doing a bar lifting task together. It's a cooperative exercise. And then the behavior of the therapist is understood and recreated by the patient side robot in future iterations. So the goal really, the way I described to you, the goal is really not to replace surgeons or therapists, but to extend what they can do or reduce their workload or make their work more efficient by using systems that have some level of semi-autonomy, different levels of autonomy. And you can do it in many different ways, by cooperative control, by teleoperation control, by integrating machine learning and artificial intelligence. And I showed you some examples based on learning from demonstrations. These autonomous systems for surgery and therapy can make things just better. They can make the task more accurate and safer, and maybe with less trauma and less side effect for the patient. There are also other benefits that these systems offer. For instance, you can create completely new treatment options, like beating heart surgery, which can't be done now. You can save on operating room times by reducing errors and also reducing costs, and enhance documentation, because any robotic system is logging all the data, and that can be used later for instance, training. Thank you so much.